we have a 52-year-old male who has been brought into ED following an ingestion of unknown liquid last 40 minutes back. So the patient is in front of you.
Patient is, sir, on primary assessment, is the patient conscious oriented?
Patient is conscious oriented. He is able to speak.
Coming to the airway, is the airway patent, sir?
What do you want to know exactly from the airway?
Airway, any pooling of secretion?
A lot of secretions are there. There are a lot of pooling of secretion, and there is frothing in the airway.
Frothing in the airway.
Yeah, and he is vomiting also.
Vomiting also. Can you just secure an IV line? With also following it, we'll get an suction also done.
Okay.
By that time, we'll continue with our assessment.
Okay.
In the breathing part, air entry is?
Air entry, you can just auscultate. Bilaterally present.
Air entry bilateral present. Bilateral crackles.
Bilateral crepitations heard.
And also, how's the respiratory rate and saturation?
Respiratory rate, you can see it is 24 breaths per minute. Saturation 87% on room air.
Okay, saturation is in the lower side. We'll put an O2 support for following the IV medication.
Okay.
And in the BP, how's the BP, sir?
BP is 90/60.
And also heart rate is, I'm getting a low pulse, sir.
Heart rate is 39 per minute.
Okay. So patient is having a hypotension with bradycardia and also a low saturation.
Okay.
With a alleged history of unknown ingestion, and all peripheral pulses, all pulses have been.
All peripheral pulses are palpable.
Okay. Coming to the disability, GCS is full score.
GCS is right now 15/50.
15. And in the pupil, how's the pupils, sir?
Pupils, you can check the pupil.
So bilateral pupils appearing pinpoints, sir. Pupils are pinpoint.
Bilateral pinpoint pupils.
Pinpoint pupils with non-reactive. Then coming to the exposure, as this has an alleged history of unknown ingestion, better before exposure itself, having a PP kit will be personal protective equipment should be needed, and also how's the GRBS?
GRBS is 120.
120. So and patient on examination, patient is also having a bad odor also. So,
okay.
Suspected.
So with this background, we have a patient of unknown ingestion of liquid. He has got one thing, he has a lot of pooling of secretion, and there is excessive sweating over the body. And patient has vomited also when after coming to the ED. And there is bradycardia and there is pinpoint pupil. So what will you suspect at this point of time?
Bradycardia with bronchoria and pinpoint pupil, high chance of organophosphorus poisoning. Okay,
so you are suppose in terms of you can call it as in a better way. You are having a patient with cholinergic toxidrome. So that will be in a better way. It can be carbamate or organophosphorus. We don't know, but the patient is having probably a cholinergic toxidrome. So what do you need to do now?
So for initially you had to relieve the symptoms. That's
what are the treatment options for an suspected organophosphorus poisoning? So, what are the things you need to do?
Organophosphorus poisoning as such treatment will be initially when the time of arrival will be an important thing. If the patient has been brought to our ER within an initial span of 1 hour, we can directly go with the gastric lavage and followed by activated charcoal.
Okay.
So activated charcoal for an adult person, 50 gram can be given. And followed by following the activated charcoal, we can start with atropinization of this patient.
Okay. More important, what I wanted to do for this patient.
Initially, after wearing the PP kit, you had to decontaminate the patient. That is, you had to wash the patient.
Skin decontamination needed to be done. Thorough wash with soap and water. The priority, as you said rightly, you have to wear your personal protective equipment before you go and touch the patient because it can be absorbed through the skin. Why it is important to decontaminate the skin?
So, patient the organophosphorus can be in the skin also.
How?
It can adipose tissue.
No, it is not the way. The patient will be drinking this, so he would have vomited with the organophosphorus into his dress, or maybe at the time of drinking it would have spilled over his dress also, and that is the reason it can be a depot preparation, sort of a depot thing, and can start absorbing. So we need to remove all the dress materials and preserve it for medical legal purpose if needed at all, and you need to thoroughly wash with soap and water. So that is the most important thing why we are decontaminating. So that is the reason why we want to wear the PP also. So you have to thoroughly decontaminate the patient. And as you said regarding gastric lavage, how will you do gastric lavage? So what are the indications for gastric lavage in an OP poisoning patient?
So indication is patient indication is main the time of ingestion is the main thing. if the patient has been coming to the ER within 1 hour of injection, we can go ahead with the gastric lavage.
Okay.
Yes.
So what are the symptoms that you will looking for, muscarinic as well as nicotinic? Can you name the muscarinic symptoms that you will see in patients?
Salivation,
Okay.
lacrimation, urination, defecation, then vomiting, then bronchoria, bronchospasm, bradycardia.
Bradycardia. So sludge is the mnemonic that you can remember, and muscarinic symptoms.
Then this is then
nicotinic
nicotinic symptoms. Patient can have like tachycardia, then hypotension.
Then you can have neuromuscular fasciculation, seizures, all those things can be seen. So what will you do if the patient is developing a seizure at this point of time?
Benzodiazepine can be.
Benzodiazepine is the drug of choice. What is the benzodiazepine that you will choose?
Short acting.
Short acting midazolam, you can be a preferred agent, 1 to 2 mg or 2 to 3 mg of IV. You can give as a bolus. If it is refractory, what are the other agents?
We can go with the phenytoin.
Phenytoin or ideal levetiracetam you can go, or else magnesium sulfate also been found to be some effective. It is not very true, but there are some evidences magnesium sulfate can be used for seizure management in organophosphorus, like we do in pregnancy, eclampsia also. So that is one thing that you need to see. Now we will come back to the patient again. Now we have confirmed that most probably clinically we are dealing with a patient with an organophosphorus overdose or toxicity, whatever it is. So what will be the, as you said, the bradycardia? You will get bradycardia in all the patients?
No, like 20% can have nicotinic effect, like tachycardia can be.
Or else?
Or else bradycardia with.
Can we have a normal heart rate, or can we have a normal heart rate?
Yes, it can.
The thing is that you have to think about co-ingestions. So usually they mix it with what?
Alcohol.
Alcohol. So what does alcohol does to the heart rate? Increases the heart rate. It increases the heart rate. It is a CNS depressant, but it increases the heart rate. So alcohol increases the heart rate, and atropine, the organophosphorus decreases the heart rate. So meanwhile, all together, the effect may be a normal heart rate also. So that doesn't mean that the patient have even got a cholinergic toxidrome. So as you said, bradycardia, normal heart rate, or even you can have tachycardia. Very rarely 10% of the patient can present with tachycardia. So don't think that you always is bradycardia and pinpoint people. Pinpoint people, yes, but tachycardia might be seen in some patients who is presenting with organophosphorus or carbamate overdose. So the next thing what you need to do, next thing what you have to decide is that you need to give regarding the specific antidote that is available is atropine and your pralidoxine. So atropine you give it for your muscarinic symptom and pralidoxine for your nicotinic symptom. Can you tell how will you select atropine? So you have atropine got here. You can tell her, give instructions, she will do accordingly.
So atropine initially itself we will give bolus doses till the bronchoria is reduced or absent. So initially we can start with.
So the nurse is coming and tell you the heart rate is 130 after giving 2 mg of atropine. So are you concerned?
No, I will continue with the.
You will continue unless and until, as you said, you have to wait for till the bronchoria is settling. So that is the most important thing. The features of clinical atropinization. The features of atropinization is dilated pupil, increase in heart rate and all. But what clinical endpoint what is want is decrease in the secretion. So that is what we are concerned about, and this is how the atropine is available. You have two preparation of atropine. This is the atropine which is available in the ampule. This is the most commonly available one. Each ml is 0.6 mg. So 0.6 mg. And when you are having an organophosphorus poisoning patient, you need to have something like this, 100 ml, each ml 1 mg. So this is what we prefer in case of an organophosphorus overdose or toxicity you are dealing with. But initially you can start off with the ampules, each ml 0.6 mg. So you have to give her an instruction. So what instruction you will give her? She has secured an IV line, and
after securing IV line, you can give 2 mg of atropine. And I will assess for the further.
Okay. So how long you need to wait for that? Around 3 to 5 minutes you can wait for the action. So you are given 2 mg of atropine.
Atropine given. I'll check for how's the bronchoria, that secretions are there, plaques are there, and also we can also look for patient is having any oral secretion, and how's the pupils. And also we can if atropinization is going on, we can see heart rate also being.
So you can see that the heart rate have gone up to 180 and saturation is 93 after you're giving your oxygen, and fluid has been started, so the blood pressure also have improved. So pupils, just imagine we have like 5 or 8 minutes after giving atropine, the pupils will get dilated. So pupils have dilated. Now what do you need to do?
If at all the crackles are still present,
you can auscultate and see the crackles are there or not. So imagine that approximately 10 mg of atropine you have given till this time. So 2 mg of atropine initially. Like this, you need to continue and see every 3 to 5 minutes how the chest bronchoria is there. If bronchoria is not there, you can stop atropine and you can start as an infusion. If bronchoria is persistent, you continue on 3 to 5 mg, 2 mg of atropine, you continuously repeat. So imagine that after giving 10 mg of atropine, the bronchoria have settled. So what will be your next plan?
So we will continue. Then we will give a continuous IV infusion of atropine.
Okay. How will you calculate the dose?
20% of atropine.
Approximately 1/3 of the total dose required. So it is 10 mg means you have to continue as a 2 mg per hour or 3 mg per hour infusion. Approximately 30% of the total required dose. You need to continue 3 mg per hour as an infusion. Maybe for the next 48 hours, you need to continue and see the clinical improvement. If you are satisfied with your secretion, you can taper down on your atropine, and maybe initially 3 to 4 days the patient might require atropine. What is the problem with atropine?
Atropine can cause CNS effects that can
cross the blood-brain barrier, and it can cause psychosis. Atropine psychosis is one of the deadliest thing that can have. So, in terms of that, maybe we can replace it with glycopyrrolate. So, glycopyrrolate is again available as ampule 0.2 mg. The same dose that is required for atropine, you can continue. But the initial phase, definitely the patient require atropine. It is not an ideal, glyco is not an ideal replacement in the initial phase. But later on, yes, you can start on glycopyrrolate. And before that, what all things you want to do? You have to catheterize the patient. That is very important. So catheterizing the patient is very important, because if the patient is not catheterized, what will happen?
Atropine causes sphincter
contraction, and you will not be able to catheterize. So catheterization is very important. And when the patient is on an atropine, he should be on an Follies. Otherwise, what will happen? He can have urinary retention and urinary tract infection. I am not. This has happened for the patient. Suddenly, somebody has removed the Follies, thinking that the patient is okay, but the patient will have urinary retention and they will go in for urinary tract infection. So that part you need to be aware of. Now we can come to the second antidote, that is the pralidoxime. So you want to give pralidoxime in all patients or in selected patients only?
Pralidoximes are given in case of organophosphorus poisoning, not in carbamate poisoning.
Okay, you can give because in the initial phase we don't get any toxicology lab values. Even setting a serum acetylcholine receptor RBC serum acetylcholinesterase level will take you some time to get. But initial phase, it is not contraindicated. Carbamate is not contraindicated. Pralidoxime is not contraindicated in a carbamate overdose. So initial phase, one more thing that I want to add is you have to send the samples for the toxicological analysis. That's what we didn't say initially, but we need to send the sample for toxicological analysis also. So how will you start pralidoxime? What is the WHO guidelines for the same?
Pralidoxime is given as 30 mg per kg infusion, that is given over 30 minutes. Then followed by we will continue as IV infusion of 8 mg per kg, then that is over next 48 hours.
40 hours. So simple thing is that you have a 60 kg individual, you have to give 2 grams stat and 500 mg per hour as an infusion. It is available as an 500 mg ampules. So 500 mg ampule. So every 1 ampule every hour. Initially 4 ampules stat, followed by 1 ampule every hour. You can continue. So what are the so that is regarding your pralidoxime. So what are the different phases of organophosphorus poisoning?
So organophosphorus have 3 phases. That is the acute phase, then the intermediate phase, and the delayed polyneuropathy phase.
Okay.
So in the acute phase, we will have the sludge mnemonics.
Acute cholinergic phase, what we have seen the patient.
Then also nicotinic symptoms. Then the next phase is the intermediate phase.
So that will take how many days?
That is usually from 2 to 3 days.
If you are not treating the initial acute cholinergic phase, the patient will go into intermediate syndrome, where the more of a cranial nerve involvement will be seen, and followed by delayed polyneuropathy, where you can have foot drop, long nerve involvement, and all foot drop, diaphragmatic palsy. All those things can develop to this patient. Suppose you are not treating the initial part, the patient can go into all these complications. What is aging?
Aging is when the acetylcholinesterase
will be irreversible later, at the time increases, it becomes
irreversible. So as the time goes on, it becomes irreversible. So that is a very important, that initial phase you have to give atropine and as well as pralidoxime. If that aging phenomena develop, we cannot do anything. So the patient will not improve. See, one thing that we need to keep in mind: all the pesticide or insecticide poisoning that is coming to the ER is not organophosphorus. So previously it was the most common one, it is easily available, but now we have to think, we have to look into the toxidrome. What are the other agents that can come to, what are the other pesticide herbicides that can come to you, to the ER? What is next mostly common that we are seeing now is paraquat. So that is again paraquat toxic. The total treatment aspect is different. Don't think that if the patient comes with some pesticide injection, give atropine. That is not the treatment. It is only when you have got a cholinergic features you need to treat like this. Otherwise, it has got specific treatment. Now, a lot of organic oils have come, organic herbicidal preparations have come. So, the total management is different. So, maybe only supportive therapy is needed for those group of patients. All patient with pesticide, you cannot label it as organophosphorus. So, that is very important that you need to keep in your mind. So, the patient is there in your ED. So, what else you wanted to start on? What are the other treatment options that you wanted to have on this patient?
So patient can have an aspiration pneumonia. So empirically we can start patient on an antibiotic.
Okay.
And also
so that is one thing. But antibiotic, any gram-positive agent, maybe amoxicillin, clavulanic acid, or crystalline penicillin initially will be sufficient enough. But later on, depending upon the requirement, you can go up on the antibiotic. Then, depending on the airway breathing, you need to intubate the patient sometime. Majority of the time, the bronchoria will be to that extent. You may need to be intubate the patient initially. Then, you prefer to use paralytic agent or not to use paralytic agent while intubating? Rapid sequence intubation.
non-depolarizing agent to use.
Have to be used. So what we use regularly? Procuronium. So that is okay. Then what else you wanted to see? You have to look in for the other electrolyte disturbances. Very common thing. This can happen because they can already heart rate. You are giving atropine with electrolyte disturbance. A lot of sweating, vomiting, everything would have happened. So you have to think of in terms of metabolic alkalosis and hypokalemia. So that is one thing that we need to correct. So electrolyte abnormality, and the patient can have co-ingestion. So that is again you need to think in terms of toxicological evaluation. If the patient, mostly they will consume it along with alcohol. So maybe a chronic alcoholic thiamine requirement, a Wernicke's encephalopathy, alcohol withdrawal. These are all things you need to anticipate in this group of patient. Now the next question is that what are your medico-legal responsibilities regarding this case?
So if a patient with a history of ingestion come, so he'll have to inform the police about the same.
You have to inform the police? Yeah. Every case you need to inform the police. That is my question. Now, as per the new amendments that has happened, every case of suicidal attempts, we need not inform the police unless and until the patient is sick or is going to die. We definitely need to inform. Otherwise, after death, yes, 100%. But otherwise, as our responsibility will be, what will be the most important? We have to, if we have any dying declaration, we have to get it documented. So, dying declaration, when you take, technically it has to be taken by a magistrate, but a magistrate is not going to come down to take a dying declaration. We can give a request to the police that such a patient has come to here and he is sick and he might die. We don't know, but he can come and take a dying declaration. If the patient, they are not going to come, it is a responsibility of any healthcare provider. I'm telling you, any healthcare provider. The patient wanted to tell something, you can document that in your case sheet. And if the patient is okay, he can get signed in that case sheet also. Nowadays, video recordings are available. Maybe you can record the dying declaration and keep it ready after getting a consent also. So, getting a dying declaration may be very important in this group of patients, especially when you are going through like a paraquat where the mortality rate is going to be somewhere around 90 to 95%. So, these group of patients, you can get, we have a clinical forensic medicine unit, so they will help us. But routinely, it is any healthcare provider. The nurse is there, the patient want to give a dying declaration, she can keep get it in writing and she can document that, and this is a dying declaration, and you can hand over to the police. So, if the magistrate is coming, ideal, or if the police can come and take the dying declaration, that is also ideal. But all the cases of suicidal attempt, we need not inform police. But when we have a patient whom you think that he is going to deteriorate and who is going to die, it is better to inform early and document all the events. If the patient has come from different hospitals, like they have already gone to one hospital, two hospital, three hospital, that might be the situation. So that pathway, the sequence of things that happen, the timing of events, all it's very important. So we need to keep up the documents of everything, and that is one of the most important responsibility that we have, along with the treating the patient clinically. So to brief it, so whenever a patient has come with an unknown ingestion, so unknown ingestion, our approach will be a toxidromic approach. What toxidrome the patient is presenting you with? Since this patient had pinpoint pupils and you had a garlicky odor, sort of a foul smelling garlicky odor, it is not definitely a garlicky odor. It depends upon the what vehicle that poison or the drug has been used. If it is alcohol, it will be the smell of an alcohol. It can mismix kerosene, it will be that. It will be a petroleum distillate smell sort of a thing. A garlicky odor is given in the textbook, but I have not seen it as a garlicky odor. Garlicky odor is sometimes it is better to have it, but it's not garlicky or it is much more pungent and it's not very, we feel irritant, a lot of irritation into your eyes and all. So the most important thing when you are approaching, wearing a personal protective equipment is very important, and most importantly, taking care of the ABC, what we have done. Go ahead with the toxidromic approach. We got a pinpoint pupil, we got secretion, lot of secretions. Then what else we have got? We got bradycardia. With this, we thought it's a cholinergic toxidrome, and we send for the labs as well as we started on atropine and PAM. And meanwhile, we are treating the other complications also. Anything else that you wanted to add? Anything specific? Okay, fine. Thank you.